So I'll walk you through the case as we go through to guide the question. 7-year-old woman had been seen by somebody else in pulmonary clinic May of 2020 and was really there for asthma and incidentally found very mild subpleural reticulations on the CT scan. And they really focused on the asthma and said, come back and get formal PFTs once the COVID pandemic has waned in a few months. And then she was lost for years. And then she came back about 2 years later and had a significant decline in her FEV1 and FVC. So we got a CT, and the read just said was progression of diffuse infiltrative lung disease. We sent a serologic workup, was negative, and the best bucket we could think of for her was idiopathic NSIP. So we end up diagnosing her with idiopathic NSIP. She's got some fibrosis, some ground glass, so we decide that immunosuppression is the way to go for her. We explain everything to her in clinic. She says, yes, I understand. We talk about slowly increasing the cell depth. I call her pharmacy. I get it arranged in her blister pack to be slowly up titrated. I explain to her the importance of the labs. We think everything is great. And then she's supposed to get labs before she goes, and she doesn't. I then am panicking because they're in her blister pack. I call her. Her phone goes straight to voicemail, which is not set up. I call repeatedly. She doesn't answer. I call her daughter, who lives out of state, who says I can never get a hold of her either. I call her assisted living facility multiple times. I finally get some kind secretary who's like, I will walk down to her unit and hand you the phone. She picks up and she's, what am I supposed to get labs for? Who is this? And so I was like, oh, we can't do this. So I took it out of her blister pack and felt so conflicted about it because over 2 years she had significant progression and ultimately it was just unsafe to treat her. So have you had similar scenarios and what have you done?
Yeah, 3 weeks ago, actually. So, your story is sounds a lot better than mine, so don't feel bad. We had a patient just a few weeks ago who I've had on mycophenolate for a few years, and he was lost to follow-up and just kept rescheduling, stringing us along. And I realized it had been a year since I had safety labs because we had lost him on our lab tracker. Because it's very hard to keep track of all these patients, as you could imagine. And the pharmacy called for a refill. And we said no. And we fortunately were able to get in touch with this patient and said, we will not refill this until you come in and have labs and we talk about this. But I want to circle back to a comment you made as you were introducing the vignette about feeling bad. And I've known you for quite some time, and I just know how conscientious and compassionate you are when it comes to patient care. I don't know that you need to feel bad about that. I think you're being thoughtful and you're making the right decision. When we all go to medical school, we're taught to first do no harm. And I think it's very important to keep in mind that we are not dealing with necessarily benign medications here. We have a real capacity to harm our patients if we're not careful. These anti-metabolite medications and methotrexate and rituximab and all these things, they're very potent. They have significant side effects. They are marrow suppressive. They increase the risk of infection. They can be hepaotoxic. They can be rarely nephrotoxic. And we can certainly do damage if we're not getting the appropriate screening labs, looking for exposure to hepatitis, tuberculosis, et cetera, knowing baselines and monitoring patients. So while it feels bad to be withholding a possible therapy that can help a patient, it also feels really bad to cause fulminant hepatic failure or disseminated TB or all these other things because the patient didn't put themselves in a position to be monitored appropriately. It's also potential malpractice. And I think we have to do the best we can. And there are patients who don't get certain types of care because they're just not in a position to. And that's why some of these conditions are hard to treat. So I think we do the best we can. And medications like mycophenolate, unlike prednisone, are medications that can be stopped suddenly. And so if there are not safety labs, they can be stopped. For the most part, our patients don't flare when we stop these. But that raises some really hard situations where we have patients who are more dependent on them.
You had mentioned the dangers of just stopping prednisone, and I was going through this case with some of the general internists on the podcast team, and one of them had the question of, okay, we can't do cell sats, but What about prednisone? Why couldn't you just put her on a higher dose prednisone? What are the upsides and downsides of doing that?
Yeah, we have pretty good data now that long-term use of prednisone compared to mycophenolate is no more effective, but it's certainly associated with much more in the way of adverse events, more infection risk, and then all the side effects that comes with prednisone. And then who's going to monitor for the side effects of prednisone, right? Bone issues, sugar issues, like all these things. She still needs medical care, right? Somebody still has to keep an eye on these things. So I would argue that long-term use of prednisone is probably as dangerous or more for her, considering the kind of dose you would need to get the same effect as you would from the mycophenolate, right? Because you'd probably need 40, 50 milligrams, a lot of prednisone. She would die from the steroids for time, ultimately from some complication. So unfortunately, it's just not a good long-term option.
Maybe talk to this patient specifically first, and then you can just talk in general. What about anti-fibrotics for the internist? Pulmonologists seem to be very excited about them, and they're seeing more and more people on them, but the general internist knowledge about them and in terms of safety, monitoring, efficacy is a little bit lacking.
So the anti-fibrotics, there's two on the market right now. The brand names are Esbriet and Ofev, or Pirfenidone and Nintendanib. They were FDA approved in 2014 in America. So this is our 10th year now. Esbriet, Pirfenidone, is now off patent. That just happened. Nintendanib will probably go off patents. Prior to that, when I was in training, when I was a med student resident, we had nothing. So if you had progressive fibrotic lung disease, it was a death sentence. We had all these trials looking at things like immunosuppression, et cetera. They all failed. So this was game changing. And because these two agents worked and were cash cows for the pharmaceutical industry, they cost $100,000 a year. This sparked a lot of new research. And so we've had many clinical trials since. They've all since failed, but we're getting closer to understanding the underlying mechanisms of fibrosis and fibroblast activation and all these other pathways. Currently, we have several phase 2 and 3 studies undergoing right now. Again, some of them look promising, who knows? But I think we'll have other agents in the coming years to add to our armamentarium against progressive fibrotic lung disease. None of them reverse fibrosis. Both of those agents, they're considered to be equal in efficacy. They both have been shown in many trials to slow the decline in FVC. So the cohorts of patients, they all continue to progress over 52 weeks. Their FVCs all go down, but the decline was roughly cut in half for the cohort as a whole. But that means some people stabilize, some people continue to get worse, but on average, the FVC decline was cut in half. We have meta-analysis data that shows that because you're cutting the decline in FVC in half, patients do tend to live longer. And we do think there's also a signal that patients on anti-fibrotics potentially have a decreased risk of having an ILD exacerbation or flare, irrespective of their baseline POTs. And so what patients have to know is if we're going to start you on an anti-fibrotic, you're not going to feel any better than you do today. So if there's any chance of feeling better, it's if you have an inflammatory component that we can maybe reverse or improve with something like immunosuppression. But the anti-fibrotic will only cause side effects and stabilize you. Now they're safe, fortunately. So we have to monitor liver function for both of these agents monthly for the first few months, and then every 3 months going forward, because very rarely they can cause a transaminitis or severe liver disease. That's very rare, but they're otherwise safe. They don't suppress the immune system or have other issues, which is good. So we have a low threshold to try them in patients who are interested and have signs of progressive fibrosis. But they have a lot of GI side effects. And so nausea, vomiting, diarrhea, weight loss, anorexia, they can be very hard to take, and you have to take them with food, either 3 times a day for Pirfenidone or twice a day for Nintendanib. And it's hard to take like a full-size meal 3 times a day or even twice a day on a schedule. So quality of life can be an issue for patients. And if the goal is to preserve quality of life and the medicine makes you feel really crummy, that's a challenge.